I think that most of the people would be knowing where India is. How many of you know there is a country like India? Two people? Yeah. So how many of you know there is Kashmir in India? Anybody knows about it? You know about it? You have been to Kashmir? You have heard about it. Right. So I'm from a place which has witnessed conflict for last 25 years. It was an armed conflict for independence of Kashmir from rest of India. Actually, there are two Kashmirs. One is with India and one is Pakistan. So I'm presenting my data. The title of my study is Common Stressors Among Patients with Attempted Suicide in Kashmir Valley. It's a Muslim majority state where almost 70 to 75% population is Muslim. I hope you will put your cell phones on silent mode for some time so that I can address you properly to avoid having two speakers in the same house. So we know suicide attempt is an outcome of a complex interaction, of three main risk factors, that's underlying stressor, disturbed mental state or psychiatric disorder, and the circumstances making access to the suicide means. There is a complex interplay of various psychological, social, and biological factors behind suicide and its attempt. Depression, other psychiatric disorders, alcohol, substance use result in an altered mental state and raise the suicide risk. These are the document's facts. Stressors in the form of environmental, social, cultural, circumstantial, financial, physical, legal, and many other adversities of short or long duration have been linked with suicide and its attempt. Suicide behaviors can be impulsive at times, resulting from frustration, anger, or as a means of manipulation. Impulsive suicide attempts can be considered as those that occur without much forethought and may not be associated with clear intention of death, but at the same time can be potentially fatal. I have a difficulty in viewing the slide from this side. Can I get the mic and I can be on this side maybe? Because impulsive suicide has been defined differently by different researchers based on time interval between the suicide thought and the attempt on a particular item scale on suicide intent scale. Stressful life events have often been associated with impulsive suicide attempts. On the other hand, we know that certain types of coping, like avoidance, may predispose a person to suicidal behaviors. Effective coping, however, act as a different from suicidal behaviors in certain individuals by helping them to deal with the stress in life. Apart from coping, interplay of other factors such as hopelessness and impulsivity may also contribute towards the suicidal behaviors. Understanding how these factors influence the suicidal behavior may help devise strategies to counteract them. That was the main of the study, why there has been an increase in suicide rates in Kashmir, and to devise strategies how to counter them. It had been suggested that suicidal attempts may be more commonly impulsive, and this is very important. In our setup, we have seen that the suicidal attempts have been more of impulsive. But in Western setup, this place, most of the times it's because of the mood disorders or psychiatric disorders in general. There is no doubt that there has been an increase in suicide rates globally. That's not a new phenomenon. That's almost now 2-3 decades old. So is the case with India. It's the second most populous country in the world with 17.5%. Contributing to the 17.5% of world population, which contributes to a significant number of total suicides in the world. Indian studies have found low rates of depressive illnesses in these attempted suicide, a finding which is at variant with Western studies. So that again says that probably it is more of an impulsive sort of suicides in India. In this geographical region, suicides are more often closely related to the adverse life events than to the psychiatric diagnosis. No, it was a normal data. Maybe some of you might have started yawning, but I will now present my own place. My place, Kashmir, is a beautiful region of snow-capped mountains, lush green Mughal gardens, and clear lakes covering around 86,000 square miles. It is nestled, more importantly, that is how the conflict started, giving an introduction of my place. It is nestled between Pakistan, India, and China, and is dominated by Himalayan mountains, which rise to around 28,000 feet. There was an era when I was a student, I was a school-going boy, before 1990, that Kashmir was like this. You would have famous Dal Lake, if somebody has heard about it. You have chilly, breathtaking Pahalgam, where snow is around 6 to 7 feet. You have Mughal gardens of Mughal Empire still there. Highest winter sporting of Gulmarg, where skiing from all over the world, people come for skiing to this place. But things changed after 1990. And what we saw, we had a conflict in the form of armed struggle for independence. We had a tsunami in one of the areas where 300 people were killed overnight. We had an earthquake in 2005 and 2008, which killed many, many thousands across Kashmirs, two Kashmirs. And of course, there was recently, again, flood, so which killed many. In fact, I think 17 people were killed, including the kids. So the scenario was different in case of mountain-locked Kashmir of Kashmir, mountain-locked Kashmir, which has Muslim majority population, because before 1990s, suicide was a rare phenomena in our setup, because as per Muslim or Muslim version, that suicide is a prohibited act. It can, although no religion permits it at all, but in our religion, it is totally prohibited and it is a sin. They say that he cannot go to the heavens if he kills himself. Subsequently, following the turmoil, armed conflict, suicide rate jumped to 13 per 1,000 population from 0.5 in 1990s. Though there was a significant peak in this, significant rise in the number of suicides.
For those number of zeros, 13 per, is it 1 million or 100,000?
It is 100,000.
Okay.
Yeah. It was 0.5 per 100,000 earlier. Now it is 13.
Okay.
Yeah. Last 2.5 decades have witnessed more than 20,000 suicides, more than 20,000. 3,000 of whom completed it, thus showing significant role played by the armed conflict. So objectives was that to study common stressors among suicide attempters seeking treatment in SKIMS Hospital, Srinagar. SKIMS, it's a multi-specialty tertiary care hospital where I am working as a consultant in the Department of Psychiatry. So it was a retrospective study done on 325 patients over the period of 5 years. A specifically designed proforma was used to record the details like socio-demographic profile, psychosocial stressors. Mini-plus was used for diagnosis of psychiatric disorders. So you can see the socio-demographic data, and as is true for many other places, the major age group was between 15 to 44. Almost 85% of patients were in this group, because you know that this is the period where you have a lot of expectations from the parents, from the teachers, and you have job on cards as well. So there are many stressors playing role in this age group. Males were more, although there was not a significant it was not significant, but males were more than the females. Rural, urban almost equal, no difference. Most of them were illiterate, or they had lower educational status. So what were the modes of suicide? We normally hear that you have gunshot or other sorts of poisoning, other sorts of suicides in different parts of the world. But in our case, it is almost predominantly, majority of them, almost 85 to 86% of them had poisoning as first mode of suicide and followed by burning. We hardly had, I don't think in my study there was a single case of gunshot suicide injury. So what were the psychiatric illnesses associated? Depression, 157, adjustment disorders, 49, anxiety disorders, 43, psychotic illnesses, 22, and this was very, very important, post-traumatic stress disorder. There was a time that post-traumatic stress disorder, as per some studies, almost 12 to 15% of population was suffering from PTSD in our state. Substance use 13 and others 24. So what were the common stressors? Even who had psychiatric illnesses, the common stressors were family conflicts in 67, marital disharmony, death of close relative, failure in exams or financial crisis, failures in love, loss of job, physical illness, other reasons which the patient did not reveal at all. So I am just on the finishing line. The finishing line is that the major stressors were family and personal issues, death or severe illness of family member, failure in exam and love affair, job maladjustment and unemployment. The results showed that stress is one of the major risk factors of suicide. So a careful and systematic evaluation of patients admitted as attempted suicides needs to be followed. We need to identify modifiable stressors to foster the coping and resilience among the host and to adapt strategies to minimize the access to suicide means to prevent them at the greatest possible extent. Thank you very much for bearing with me. So if you have any questions or any queries, you can send me on this email. Any comments or questions would be welcome. If I am not able to answer, I may answer it through email once I study, go back home and study.
The low rates of gunshot wounds, is there?
Yeah, it is, yeah, I expected a question from you and the same probably. The reason is that there was a time, there was an era where there was a gun culture. Almost every, I won't say every home, but cluster of 10 or 15 homes or a town would have many guns around. But still, culturally, that is not acceptable. The gun is not acceptable in our part of the world. It has been a peaceful area for centuries together. And gunshot, I did not find a single case. Although it is the way the armed struggle was there, we never found a gunshot injury because poisoning and poisons are not that difficultly available. They are easily available over the counter. So the people have easier access of getting these. To the guns, it is very difficult to have an access to such means. Yeah, please.
I am interested in the treatments you use. To what extent are medications used in comparison to psychotherapy?
There are basically two groups of patients which we divided into. Those who had predominantly stressors and those who had stressors followed by psychiatric disorders. Who had stressors only, not leading to major psychiatric disorders, only to psychiatric symptoms, they were monitored over the period of time and psychotherapy as per the diagnosis was given. But like PTSD, you have EMDR, you have CBT and other therapies which were given. But to those patients who had a classical diagnosis or a disorder resulting in their disturbance in day-to-day activities, they were started with drugs. And mostly in our place, we use SSRIs. We use SSRIs, plus we use mirtazapine. And mirtazapine probably was used in Kashmir much earlier for PTSD than other places of the world, because one of my teachers under whom I have done my post-graduation, Dr. Mushtaq Margoob, he started using mirtazapine for PTSD initially. Then we found that it's being used at other places also. So SSRIs were the mainstay of the treatment in the patients who were diagnosed with psychiatric disorders. My part is over. Thank you so much again. Thank you.
Need a little stretching exercise? Anything else I can do to help you? I have just a few minutes really, today, to speak of an unusual way of thinking about some of these problems. Addiction, you know, and how it can be treated most effectively. Now, I am going to speak of an unconventional method of psychotherapy. This method is based on two primary assumptions. First, that we are conditioned creatures. that events in our lives impact us, condition us with effects that may be either psychological or physical. We speak of these problems as being psychogenic problems. I consider depression to be a psychogenic problem. It's the consequence of earlier experiences. Now, I know traditional psychiatry will debate this with me, contending that depression is the consequence of chemical imbalance that can be corrected. Well, I grant much correction can be done, but I see the chicken and the egg issue the other way around. I think the chemical imbalance is a consequence of emotional influence through the medium of smooth muscle impacting the glands. Well, now getting back to addiction. What is there in common? Addiction, excuse me. In clinical terms, we talk about withdrawal, we talk about tolerance, we talk about things of a physiological nature. But if you examine it consistently, you will find that the roots of the problem are psychological. You know, one of the biggest driving forces to increase and further the continued use of a drug is the fear of withdrawal. Well, anyone who's spent any time in a detox center will fully recognize the significance of that. How would anybody ever want to go through such an experience again? So fear of withdrawal prompts continued use. Well, you see, we're back now to fear. That's a psychological problem. They begin this behavior that led to the addiction at some point in time, for some reason. Whatever that reason was, it was legitimate. It was real. It had value then. Now, it does not. A simple illustration of this would be smoking to addiction. Addiction to smoking. Yeah, thank you. Why do we begin smoking? Well, I can tell you why I did a long time ago. Peer acceptance. And I found that to be the most popular reason to begin, by far. Well, it's valid then. Now, years later, your patient is desperate sometimes to cease that, to stop that. It's killing me. By the way, do you mind if I smoke here in your office? Well, if you're open to just the possibility that addictions are psychologically based, that they are psychogenic, then treatment should be psychological. You know, conditioning begins when life begins. We can get into big debates about when life begins, but conditioning does begin at the beginning. Fetuses will respond to their mother's voice and so forth. The upside is that when conditioning has resulted in a problem, it's reversible by exposure to new information. We can understand it differently, and then the consequence, the effect, changes. A little child lost in a big store. Little child's fried, truly afraid. genuinely afraid. But that little child, now an adult, remembering that experience, understands it completely different, and so the effect changes. This method has some real advantages over other psychotherapies. This method that I call subliminal therapy. And one of the really unique features is the second assumption upon which it's based. The assumption that all people have mental capacities that exceed conscious capacities, conscious abilities. Now, I see evidence of that everywhere I look. But the big thing that demonstrates the reality of that to me is the fact that we're alive. If you stop to consider the level of sophistication of the intelligence required just to keep us alive, regulating all of the vital functions of the body in response to the environment, I don't think we can even comprehend the task, much less execute it. Well, this method taps into that higher level, that extra conscious level of intelligence to do the work of therapy, effectively bypassing the limits of consciousness. Anybody who does psychotherapy knows that it's true. The big hurdle is getting over resistance. Well, what is resistance? Resistance can come in the form of beliefs, of assumptions, of convictions that aren't real. When you get to the core of a problem, when you identify the actual subconscious cause of a psychogenic problem and resolve it, the symptom ceases to exist. It's just not there anymore, whatever it is, whether it's migraine, headaches, behavioral problems, anxiety, depression. I've concluded that all of these are psychogenic, and I have very substantial evidence to demonstrate that it's true, based on the effectiveness of this treatment, focused in that mode. Identify the cause, well, and then resolve it. Once you know what it is, resolution can happen by reframing or by other methods. But consciously, the patient never knows why or understands why they have the problem, and are consistently surprised to learn what the real cause was. And they've used this method. Non-chemical addictions, it's the same theme. Addiction to a person, addiction to gambling, the same elements are present. And if it's psychogenic, the same treatment is required. In using this method, the success rates overall, if anyone is interested in pursuing this, in questioning this, wanting more data, that slide will be up in a moment. This is a summary, because I have such a short period here. In treating chemical addiction, 90% effectiveness. Well, now that's just not believable by most clinicians. You can't do that. Well, The Mexican government has undertaken a 400 subject, very well designed, blinded study of 400 subjects with chemical addiction, most of them young people. Mexican government I got their attention teaching this method there. I hope to get your attention teaching this method here. And that teaching starts at 4 o'clock this afternoon. There's the site to go to if you really want to dig. All of the data is there. Those numbers I just showed you are based on a review of the analysis of the data I have been obtaining from my patients. I don't yet have the traditional validation of controlled research. What I do have are the objective reports from my patients that I collect before treatment, after treatment, and where possible, follow-up. But that's difficult. Thus far, I'm now approaching, I think, 400 cases. That's where those numbers came from. I didn't imagine them. My patients created them. The website there is the website of the nonprofit institute I created several years ago with the objective of researching, promoting, developing this method. And there is a wealth of information there. I encourage each of you to go to that website. On the home page, you'll find my picture. Click on my picture for a 5-minute video I think will really impress you. Questions? Anybody? Well, if you think of them, come at 3 o'clock. I'll answer them. That's the very